Good morning. I'm Dr. Mark Erkin, Professor of Otolaryngology and Director of Head and Neck Surgery at Beth Israel. I'd like to welcome you to your head and neck surgery rotation at BI. We have prepared this video as a way of introduction to the head and neck service to give you some details about what to anticipate and how to succeed on this service. I represent my colleagues on the head and neck service who have provided input to the creation of this video and would like you to watch it in its entirety and then to sign a note at the end with the academic secretary confirming that you've completed the video. Thank you very much. Good morning. I'd like to welcome you to the head and neck service at Beth Israel Medical Center, and what I'd like to do is use this as an introduction for you as you start your rotation. I think it's important to understand what our expectations are of you as you begin this 3-month rotation in order to make it the most productive educational experience for you. What this video is intended to accomplish is to give you a framework for starting your rotation and understand what we would like to see as part of the clinical service as it relates to the head and neck population of patients. It is by no means a replacement for direct communication with each of the attending surgeons, and certainly every single attending will have some variation on a theme as with respect to their approach to surgery and patient care. So what should you try to achieve during this rotation? You should try to appreciate how to manage complex head and neck cancer patients. You should gain an understanding of the preparation that's involved in achieving a successful outcome in the management of both basic and complex head and neck surgical patients. You should achieve an understanding of how to perform both basic and advanced head and neck surgical procedures. Obviously, this is dependent upon your level of residency training during this rotation. And you should gain an understanding of how to manage postoperative complications following head and neck surgery. This is your time to learn this. This is far better time to appreciate what's involved in postoperative care and the management of complications than when you have to face this for the first time after you've graduated. And finally, there are innumerable opportunities for writing basic clinical papers or becoming involved in longer-term research projects. If that is a goal of yours during this rotation, you should certainly make that clear from the very outset. So some of the general expectations that I'd like to cover in more detail include professionalism, what our expectations are with respect to patient care, and how you should interact with the staff both in the hospital and in the outpatient setting. As far as professionalism is concerned, we take this very, very seriously. And it begins with your attire. Your appearance is absolutely a direct reflection to the patient of the quality of care that they will receive. The corollary to this is that a sloppy, unkempt attire does not convey the impression of a clean and sterile healing environment. Clean clothes and a tie for men are expected whenever you're not in scrubs. And as you know, scrubs that are from the operating room are not to be worn outside the hospital. And it is certainly your responsibility to have a clean white coat as part of your attire. This is an absolutely essential part of this, and you must make sure that that coat does not convey secretions, blood, or dirt as a result of your failure to adhere to this particular expectation. As far as your conduct, this is vitally important, and I can't emphasize enough that we expect you to conduct yourself in a professional manner in your relations with patients and the support staff. It is imperative that you understand that while you are on the ward, in elevators, in the operating suite, in the holding area, in the PACU, everything that you say can be overheard by patients or family members, and it is imperative that you do not violate this particular code of conduct, which is extremely important and one that will serve you well throughout your career. You indeed are a representative of the attending staff and the entire organization. And we expect that you will represent us well while you are here at Beth Israel. One of the important points to understand is that the information that is conveyed to patients and their families as it relates to their clinical care should come directly from the attending. Unless you are specifically instructed that by the attending to convey certain information, you should not inform a patient or their families about the details of their surgery, pathology reports, or other diagnostic studies. As it relates to patient care, you play a critical role in the management of patients with complex medical and surgical problems, and these patients whose clinical course can change dramatically and quickly. You are the front line, along with the nursing staff, along with our nurse practitioners and PAs. But obviously, we rely upon you 24 hours a day, 7 days a week, to be our eyes and ears as it relates to understanding what is happening to a patient so that we can provide the best possible care. It is imperative that you respond to your pages and your calls and that you come to evaluate a patient whenever requested by a nurse, a family member, a nurse practitioner, or a PA. One of your major responsibilities is indeed direct patient care during the perioperative course of patients in the hospital, as well as patients being admitted to the emergency room. I cannot emphasize enough that communication is the key to a successful patient outcome. You must communicate to the attending any significant change in the clinical status of a patient, regardless of the hour of day or whether it's a weekend. I can only tell you that it is far better to have an attending tell you that they did not need to know something than for them to find out that they wanted to be actively involved in guiding the decisions made about their patient. It's important that you don't forget that a patient's family will call the attending to inquire about the patient, and it is imperative that the attending be aware of important changes in that patient's status. The third expectation is related to your interactions with staff in the hospital and in the outpatient setting. And at the very beginning, it's important to understand that we are fortunate to have a head and neck fellow on service, and that fellow is indeed an extension of the attending staff, but is not ultimately responsible for the care of any patient on the service. That responsibility lies solely on the shoulders of the attending. The fellow does provide a level of experience that will assist in your education and in your journey on the head and neck service. As far as the nurse practitioners and the physician's assistants, both in the hospital and the outpatient setting, these are highly experienced individuals in head and neck patient care. Their requests, concerns, and questions should be taken seriously and responded to immediately. These individuals are professionals and should be handled and dealt with in a professional, collegial manner. I would like to start off this with telling you some pointers as to how you can maximize your experience from an educational perspective while on the head and neck service. Every attending surgeon that you operate with during your rotation provides a wealth of experience, and you should not waste that opportunity. Take the opportunity to ask questions and try to understand why the attending does what he or she does, both in their approach to a clinical problem as well as specific aspects of their approach to a surgical procedure. When you are on service at Beth Israel, every attending surgeon that you operate with during your rotation provides a wealth of experience. Don't waste that experience. Take the time now and the opportunity to ask questions, no matter how small they may seem. But it's this time for you to understand why the attending does what he or she does, both in their approach to a clinical problem as well as their approach to a specific surgical procedure. This is the time to ask questions of surgeons who have learned from their mistakes so that you don't have to make them when your time comes as an attending. The more that you put into this rotation, the more you will take away, and the lessons you learned will serve you well for the rest of your career. Your experience on the service, both in and out of the operating room, will undoubtedly be affected by your level of interest, your enthusiasm, and your commitment to the learning process, and how effective you are in displaying that enthusiasm and commitment. It is far better for a resident to have an inquisitive mind and an inquisitive approach to the learning process, and I can assure you that attendings will feed on that level of curiosity. Surgery is a discipline and a major responsibility. The quicker you adopt that understanding, the quicker your maturation as a surgeon will be. You must commit to learn everything there is to know at this point in your career. Ask your attending what you should read. And one word to the wise is to find out what your attending has written and published about a particular topic, because it is certainly fair game that they will expect you to know that in the management of their patients. Be smart. The more you convey your commitment to your profession, the more an attending will embrace the role of teacher and mentor. This is undoubtedly a two-way street. Failure to prepare for a case, both in knowledge and technical skills, will demonstrate a lack of commitment to that process. I encourage residents to keep a record of how an attending conducts every aspect of each surgery. And I encourage you to either have a notebook or a 5x7 card with a filing system that allows you to refer back to that particular attending's approach before each and every case. And this relates to how does the attending prep a patient, how do they position them, what specific instruments they tend to use in performing different portions of the procedure, how do they dress the wounds following the completion of the procedure, and what are the certain aspects related to patient care that they have that are unique to that to their system of managing patients. This information will serve you well when you graduate and you're out on your own. It is part of the learning process to be exposed to multiple approaches to the same problem or procedure that you can record from different attendings that will allow you to create a hybrid approach that is unique to you. This level of commitment will immediately demonstrate to the attending that you value the experience of working with them and that you are committed to maximizing what that experience has to offer. Don't wait until you're a senior resident to begin this process. You should start to record information during your first rotation in your PGY1 year. Begin now. The discipline involved in taking notes after every procedure will put you in great standing when it is your time to play a greater role in your subsequent rotations. These are the expectations when you arrive in the operating room to assist in a surgical procedure. Understand the details of the patient's history. Understand the indications for surgery. Review the imaging studies. Know the anatomy in tremendous detail. And know the steps in the procedure. If you have not committed to these 5 pieces of information, then you are not prepared to come to the operating room, and the impact of that will be significant with respect to what you're allowed to do and what your role will be in that surgical procedure. You are training to be a surgeon. There are certain skills that you must commit to in order to become proficient as a surgeon. Know how to perform a two-handed surgeon's knot and the sequential square knots. This is basic technique that you must know and learn it now and be prepared. This is something you should master as a PGY1, and you should be able to do this in your sleep and without having to look at your hands. This is something that you must practice, practice, practice in order to master. As it relates to specific aspects of post-operative management, one of the things that's important is to understand placement of a patient in a step-down unit. We tend to place patients who have any difficult or unstable airway, and this includes a fresh tracheostomy. We immediately place patients from the SICU after they're discharged directly into the step-down unit for further monitoring. When a patient is positioned in the step-down unit, it's imperative that you understand some of the sensitivities given the size of that step-down unit. And so it's important for you to appreciate that if a patient has gone through disfiguring surgery that leads to facial deformity, that other patients may and their families may not be in a position to be able to deal with that well, especially if they're recovering from their own surgery. Gender placement with respect to the unit is very important, given the fact that of the close proximity of the beds. It is far better to place men on one side of the unit and women on the other when we have the freedom to do so. You should also be extremely aware of the level of consciousness and/or unruly behavior of a patient on one side of the unit. This can be extremely disruptive to another family or another patient who's trying to recover from surgery. As far as drains are concerned, you must appreciate the fact that these are two-way streets, and they must be dressed appropriately both while the drain is in place and following removal. It is imperative that every drain site be dressed with an appropriate dressing. Tracheostomies must be securely positioned, but no ties around the neck during an early postoperative course in a patient with a microvascular free flap. This is imperative, and I'll come back to this point in just a moment. It is your responsibility when you go by to see a patient or when you're called by a nurse to make sure that you check the position of the tracheostomy tube as well as the inner cannula and to make certain that the patient is breathing comfortably and that there's no signs of stridor to indicate that the tube has clogged or become dislodged. Feeding tubes that are placed into a tracheoesophageal puncture must be secured and rechecked. If these become dislodged, they must be rapidly reinserted before the opening has a chance to close. The implication of this is that that patient may require a return to the operating room should that opening between the trachea and the esophagus close and not be able to be recannulated. As far as microvascular procedures are concerned, there is a tremendous amount that goes into the successful completion of a microvascular free flap. These are highly complex procedures, and preparation, implementation, and postoperative care are vital to the success of that intervention. In the beginning of every case, when the patient arrives in the holding area, it is imperative that you know the donor site that has been selected and be able to communicate that with the nursing staff as well as the anesthesiologist. It's important to know which side of the body will be harvested. The only way to find that out is to discuss that with the attending or the fellow, and don't assume that you know the answer from reading the patient's records. We select the donor site in the office setting based on a variety of factors that are unique to the patient and to their anticipated defect. In select circumstances, more than one donor site may be considered and may need to be prepped and draped. The utilization of a variety of different donor sites may be determined during the operation after the ablative portion of the procedure has been completed. In almost all instances, the consent will include the harvest of a skin graft or a regional flap such as a pectoralis major flap, and these must be prepped in during the preparation of that patient. The details of prepping and draping of a donor site are unique to each of the donor sites, and this will be reviewed with you by the fellow, the attending, or the nursing staff in the operating room. One thing that is imperative is that for scapular or latissimus flap harvest, a beanbag must be placed on the operating room table, and that patient must have an axillary roll placed. As far as postoperative care is concerned, place instructions at the patient's bedside on a paper that is taped to the head of the bed. If there are specific blood pressure parameters, which we most often have, and it's usually a systolic pressure, in the range of 120 or above, it's imperative that that is displayed. Most often, patients will be placed on dextran for 5 days after surgery, as well as aspirin during the postoperative period. Patients are continued on aspirin following discharge from the hospital. Communication is vitally important to enhancing the quality of patient care. You must understand the specifics of head positioning from the attending and the fellow, which is usually determined at the completion of the microvascular portion of the procedure. It is at that time that we determine how much redundancy there is in the pedicle and whether or not turning of the head from one side to the other may lead to either kinking or stretching of the pedicle that can be catastrophic with respect to the health of the flap. As I've mentioned before, there should be no trach ties placed around the neck. The trach should be sutured into place until the latter part of the patient's postoperative course, usually by post-op day 7 or 10, when the attending tells you that it's safe to put a trach tie around the neck. Free flap monitoring is a vital role that we play in making sure that we identify at the earliest possible time that there has been a compromise in the circulation to a flap. This is absolutely critical to achieve the type of success rates that we have enjoyed on the head and neck service at Beth Israel. And this process begins in the operating room as soon as the anastomosis is complete. It is imperative that the flap be checked periodically during the closure. You can never assume just because the flap was just vascularized as a result of completion of the artery and the venous anastomosis that flap is good until you get to the recovery room or to the surgical ICU. Make certain that you know the exact location of the flap and the path of the pedicle. Know where the portion of the flap that is going to be monitored is exactly located. Know what the specific concerns about the flap are from the discussion with the attending and the fellow. Head positioning, as I just mentioned, may be extremely important to the success of this patient's care, and you must make certain that you understand that and that information is conveyed not only to your fellow residents, but also to the nursing staff and displayed appropriately. Do not place a tie or tight dressings around the neck. If a cephalic vein has been transferred, then the area over the clavicle must also be free of compression. Make certain, and again I reiterate, that all instructions that are specific to a particular patient are placed in the chart and on a paper that is prominently placed at the patient's bedside above the patient's head. Postoperative free flap monitoring begins not only during the closure, but immediately after the patient is checked into the surgical ICU or the step-down unit. It is imperative that flap checks are recorded on an hourly basis during the first 48 hours, and then on starting at 48 hours, it goes to every 2 hours, and then on the fourth day, it goes to every 4 hours, which is continued through day 5, and then goes to once every 8 hours on day 6 and beyond. The information related to your findings must be recorded at the bedside on the flow sheet. When you arrive at the patient's bedside, you must be aware of where the monitoring paddle is located. The first thing you should do is check the patient's blood pressure and their head position. It is invariable that a family member or a nurse will place a pillow underneath the patient's head that may drastically alter the perfusion of a flap. Assess the color and the capillary refill before you place a needle to assess the bleeding. The color of the flap and the appropriateness of the refill can be extremely important indicators of the health of that flap. A 25 gauge needle should be used to assess the circulation to the flap. It is important that you don't place this needle deeply into the flap when you're dealing with a very thin flap such as a radial forearm flap. The importance of that is that the circulation to the flap may be just underneath the skin and may be compromised by the development of a hematoma. The egress of bright red blood from the needle stick is key. Dark blood or no blood is potentially problematic. And the most important thing is the development of a change in any parameter that must be evaluated further. If a flap is underperfused, it's referred to as an ischemic flap. It reflects a flap that has poor capillary refill or no capillary refill and the inability to obtain free flow of blood after a needle stick. A flap that demonstrates venous congestion is often one that demonstrates a blue color, and it is, in order to be able to assess this well, it is important to assess that portion of the flap that is at a distance from where needle sticks have occurred. Often, in the process of checking a flap after 24 hours of needle sticks, there is ecchymosis that results from the needle sticks themselves, so it's important to get a look at the flap away from where those needle sticks have occurred. Rapid capillary refill is a sign of venous congestion, along with dark blood from the needle stick, as well as continued bleeding from the flap stick site itself. These are all a reflection of a compromise in the egress of blood out of that flap. What is the importance of flap temperature? Absolutely zero. It is a meaningless parameter and one that should not be part of your assessment. What do you do if there's a change in the free flap parameters? Check the blood pressure, check the head position. If those are not appropriate, recheck the flap. If the pressure has been low, make certain that you communicate with the ICU staff in order to get the pressure up within a very short period of time. Normally, we do not like to use pressors that cause vasoconstriction for obvious reasons. Once the perfusion pressure has gotten above 110 or preferably 120, reassess the flap. If it has not improved, call the fellow immediately. Time is absolutely critical. If there is a true change in the status of the flap, then the attending must be notified immediately with the intent to return to the operating room on an emergency basis. This is truly an emergency where time is of the essence. As far as preparation and intraoperative positioning and other details of the case, it's important to identify whether a nasogastric tube is required for that case. It is far better to place that tube and secure it prior to the formal prepping and draping procedure. Proper securing of the nasogastric tube should include a columellar stitch as well as tape to the nose. This method of securing a tube will prevent untimely displacement and the need to replace it during the postoperative period. It is far better for us to assess and check to make sure the nasogastric tube is in the proper position in the stomach so that we can reposition it during the procedure and not during the postoperative period when suture lines may be at risk as a result of replacing that tube. This slide demonstrates a properly taped tube that has also been sutured into place. The expectation is that this will remain in place or be retaped during the postoperative period, and that tube will be checked on a regular basis to make sure that it is properly secured. The placement of a proper head drape is an extremely important part of preparing for the head and neck surgical procedure. It is the surgeon, the resident, the PA's responsibility to make sure that the endotracheal tube is absolutely secure at the very outset of the procedure. The key to this is not just the tape around the mouth as shown in this slide, but even more importantly, the placement of the head drape and making sure that it is secure and that the tube itself can be positioned properly and secured. You cannot secure a head drape and the tube too securely. No patient has ever died due to a tube being too securely taped into position once that you assure that the tube is in the proper place in the airway. The displacement, however, of that tube during the procedure can lead to an emergency, to a break in sterility, and a catastrophic outcome. This picture reflects an inadequate job of securing this tube at the outset of this procedure. This tape has pulled away already and is not doing the job that it was intended to do. This is a far better securing of that tube to make certain that you can actually pull this the patient's head off the table if you were to hook your finger underneath the tube. That's a good acid test to make certain that that tube is properly positioned and properly secured. This shows how a head drape should be placed. It should be applied prior to the induction of anesthesia. It is imperative that the silk tape be used to secure the head drape and that the tape must be applied to the skin of the posterior aspect of the neck. If you don't achieve this goal of placing the tape directly on the skin and the nape of the neck, then this head drape can never be secure. The tape should be applied to the forehead skin, but not to the eyebrows, and you should be certain that you don't apply pressure to the architecture of the ear in order to prevent necrosis. Make certain that every point where a disconnect can occur is securely taped after you personally check to make sure that it is secure. Every connection in the pathway from the patient to the anesthesia machine must be checked, and it is your responsibility to make sure that it does not come undone after the drapes have been applied. There are types of surgery where the position of the tube, of the endotracheal tube, will vary, but this does not alter the need for that tube to be secured as shown here. There are select cases where a Maloney dilator will be placed prior to the prepping and draping procedure. That tube should be, or that dilator should be secured as well in order to make certain that it either does not come out or migrate during the procedure. We're going to shift gears here for just a minute and talk about thyroid and parathyroid surgery. It's imperative that you know exactly what procedure is to be performed. It is your responsibility to know that what has been written in the consent corresponds with the patient's history, a review of their imaging studies, as well as the cytology. Make certain that you have checked and rechecked which side has the pathology to make certain that the appropriate consent and marking of the patient has been achieved. Find out from the attending what type of anesthesia is to be used for this procedure. Whether it is to be done under general anesthesia or with a regional nerve block and sedation has been discussed in the office during preoperative consultation. Find out from the attending whether they want a monitored endotracheal tube, and also find out whether monitoring of PTH during the procedure is to be employed. Most often, monitored endotracheal tubes are used in revision surgery for large thyroid goiters and for patients undergoing cancer surgery for a thyroid malignancy. Every surgeon may not elect to do this, but I mark every thyroid and parathyroid incision prior to prepping and draping so that I can feel comfortable about the exact position of the scar. Often your field is limited and distorted as a result of placement of the drapes, and at the appropriate time to mark a patient is before the application of those drapes. As far as application of the dressing, this is the way that I elect to do this. I use a subcuticular closure. I apply a dermal adhesive Dermabond. Following this, I place a steri-strip just measured over the incision. Subsequent to this, I place a Telfa pad that has been cut so that it extends beyond the limits of the steri-strip. The importance of this factor is that once you apply the last phase of this, which is the tegaderm, that tegaderm will lift off the steri-strip if it's not completely protected by the Telfa pad. So the Telfa pad must be cut appropriately so that it extends beyond the margins of the steri-strip before you apply the tegaderm. As far as postoperative management is concerned, make sure that you begin thyroid replacement if a total or completion thyroidectomy has been performed. This can be, the appropriate dose can be done on the basis of a formula regarding the patient's weight. Patients that have been on thyroid meds prior to surgery will likely be placed back on them after surgery. If there is any question about this, direct them to the attending surgeon, but make sure that this is directly written into the records in order to ensure that a patient is appropriately medicated postoperatively. Calcium and vitamin D replacement may be gauged on the results of the intraoperative PTH monitoring. The normal guidelines that you use are that if the PTH at 10-20 minutes following the procedure has dropped below 5 or is deemed to be undetectable, this will usually lead to the initiation of therapy in the PACU with a gram of calcium in a minimum of 500 cc's of saline. It is imperative that this amount of calcium be diluted in order to prevent severe complications should it extrude from the venous site in the arm. Oral calcium and vitamin D may be started immediately, and once the determination that a plateau in postoperative total calcium has been reached, it is only then that a patient may be discharged from the hospital. It is possible that there is a need for calcium check after discharge, requiring that a script be given to the patient so that they can go to a local lab and have the results phoned in to the attending surgeon. I want to conclude by recommending that you look upon this as a learning experience and an enjoyable rotation. Don't be afraid to ask questions when you are uncertain. You are here to learn. You are here to work hard. And you are here to understand and appreciate that surgery can be enjoyable and tremendously satisfying when done well and done safely. Good luck.